Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have here a patient who attended with bilateral fully occluding earwax, and I'm just starting with their left ear. They have a narrow ear canal entrance, which is somewhat collapsed. So I'm just using the suction probe to lift the entrance of the posterior portion of the entrance of the ear canal. So when I say posterior, I mean the back parts. You'll see that again in a moment. So I'm inserting the suction probe. I'm just lifting that back portion of the cartilage which makes up the entrance of the ear canal, and I've just instilled some olive oil medical grade spray in here to change the consistency. This wax is quite mushy, glutinous, and it's difficult to vacuum. It keeps blocking the inside of the suction tube. So what the oil does, it not only does it lubricate the inside of the suction probe to help prevent blockages, but it also helps to bind the wax together. So if you do suction it comes out in larger pieces. There are a few hairs here at the entrance, and sometimes they can partially obscure the view. There's not much really you can do with that. So one of the questions we often get asked is it why don't we trim the hairs? But trimming those hairs, the only time I'll consider removing those hairs is if it's literally no visibility at all. And I've had to do that once or twice. And we wouldn't trim them, we'll actually just pluck them. We'll get some crocodile forceps. It's a technique that was taught to me by an ENT consultant who's a friend to Mr Rajali. Otherwise, those hairs are just best left alone, because trimming them, they could fly into the ear, mat against the wax, making it harder to remove. Also, with these hairs, they do serve a function. They help to filtrate the air that's entering the ear, so it helps to collect any debris, dirt or dust, foreign bodies. And also the follicles of these hair strands are the sebaceous glands, and the sebaceous glands secrete sebum, which is a lipid oily secretion which partially helps to form earwax. But sebum's quite important. It's acidic, so it helps to repel insects, also helps to inhibit bacterial fungal growth due to its acidity. It's oily, so it helps to moisturize the skin and help to hydrate it. And also these hairs will just grow back, so it's not a long-term fix. And potentially, if you cut them, you may lead to folliculitis, so an infection of the hair follicle, which then can cause furuncles or a boil full of pus or blood even. But just want to get the endoscope through if possible. Sometimes the wax is right up against the entrance, so when you insert the endoscope in, there's not much you can do. It's right in contact with the hairs. But here, just because I'm getting a bit deeper now into the ear, I'm able to insert the endoscope just past those hairs. Occasionally when you enter the ear, because his hairs are slightly oily as well now, they can smear against the lens. But as you can see, it's not affecting us. You still get a good enough view. Slowly but surely bring this out. And as I was bringing it out, because the plug's larger than the entrance, it separated it subdivided whilst I was bringing it out. I think there's one more piece actually. Let's have a look up against the eardrum. There we are. It's quite a long piece as well. So these hairs, just going back to them, they should only be located in the outer third of the ear canal as well. That's where the skin that lines the outer third has the three layers, the epidermis, which the whole ear canal has. But the skin that lines the outer third, the cartilage portion, also consists of the dermis, so it's the middle layer, and also a subcutaneous layer, which is made up of insulating fatty tissue and connective tissue. So the skin that lines the cartilage portion is far thicker. It's about 1 millimeter in thickness in comparison to skin that lines the inner 2/3, which is just the epidermis layer. So this patient's got quite a prominent inferior recess. There's a big trench at the bottom of the ear canal, and also an anterior recess. The ear canal wall on the front section, it slightly protrudes into the midline and it goes back in again. That creates a little recess. We call that the anterior recess, and it would appear that the wax got trapped behind that. That's hence why it wasn't migrating and it formed into a plug. So just there right here, so I've just instilled the drops in straight away. I'm just kind of mopping up some of the excess oil. I'm just using the endoscope as well, the left side of the tip of the endoscope, to stretch the ear open. And just vacuuming some of the excess oil. just got a bit too blurred. So I'm just going to wipe the lens again. I'm just going to go over the hairs on this occasion. I can go in a bit deeper now because it's starting to clear the entrance, which obviously then means there's less smearing. And the oil helps to bind this together. It's still quite impacted and compressed against the side walls of the ear canal. So this is the posterior section, the back part of the ear canal. You can see it just slightly blocked the tube, so I just give it a little wriggle and it unblocked it. It's quite glutinous, as you can see. There's a few hairs that are matted within that section of wax as well. I think I've just put a bit more oil as well now. Indeed I have. And there's that blurriness. I'm just going to suction some of the excess first. And just mop up the entrance. And then I'm just going to insert the insert back in, stretch the ear open. Again, as you're suctioning, what happens, you suction some of the oil so it does blur the view. But once you get past that, you can see it's a lot clearer now. And see, because we're clearing the entrance, we can go in a bit deeper, past those hairs. And this, you can see how compressed this plug is. It's really impacted. I'm just trying to separate it from the back part of the ear canal now. And slowly but surely I can feel it loosening. We've got a big plug that just came away here. Just going to wriggle that out of the ear. Just going to re-enter. You can see you've got this fibre plug which is a lot deeper in the ear. It's still quite impacted, just trying to loosen it. So just tugging away at it, little movements left to right. And you can see that plug is engulfed with a layer of skin. So I don't have any still images. So one of the things we often get asked is to always get asked if you can provide still images. Sometimes there is no still images because a lot of the wax gets suctioned to tubes, but also sometimes we're just so busy in clinic. I don't have time to take photos because we've got the next client waiting, got to wipe down, write the clinical notes, prep the room for the next patient, do all the decontamination. So if I've got a really, really busy clinic, it's just not possible. So, but if there is opportunity, I do, but sometimes it's just not. The eardrum's visible, the handle of malleus, so the hammer bone, you can see all the blood vessels are dilated. That's fine, just a bit vascularis. Most likely because of the wax plug was right up against the eardrum. But, well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.